So it's now 9:01. I think we will start now our webinar. So good morning, good afternoon, good evening, everyone. It's my pleasure to welcome you to the third pre-ZOD webinar on equity issues, zoonosis prevention, and how to lift barriers to inclusivity. In July 2020, as the world was deep down in the COVID-19 crisis, the Secretary General of the United Nations, Antonio Guterres, emphasized the severity of the pandemic's consequences. He stated, "The pandemic has demonstrated the fragility of our world. It has laid bare risks we have ignored for decades: inadequate health systems, gaps in social protection, structural inequalities, environmental degradations, and the climate crisis." We know now that the emergence of another infectious disease could further deepen disparities. And this is even more relevant for zoonotic diseases, as these encompass multiple health sectors. The PRESERVE initiative is about preventing zoonotic disease emergence. It has been created to put prevention at the heart of pandemic preparedness and response. If we want prevention to be effective, efficient, proactive, and therefore successful, we have to make sure that it is inclusive. This means that we must ensure equity in all the forms of prevention. I am pleased to welcome today a great panel to discuss this topic. Around our virtual table are Professor Robin Alders, Honorary Professor with the Australia National University Development Policy Centres and Senior Consulting Fellow with the Chatham House Global Health Programme. We have Dr. Salome Bukashi, Professor of Research in Anthropology in the Department of Anthropology, Gender and African Studies at the University of Nairobi in Kenya. We have Dr. Amélie Deva-Larive, Associate Professor of Infectious Disease Epidemiology at the University of Veterinary Medicine of Vienna in Austria. We have Dr. Andrés Garchitorena, researcher at the French Research Institute for Development and PRESERVE focal point for the Indian Ocean. And we have Dr. Sandul Yasoband, Assistant Professor at the Indian Institute of Public Health in Gandhinagar in India. Thank you all of us. Thank you all of you to join us today. I just, before we jump into the discussion, want to remind our audience that we have a Q&A box open, so do not hesitate to ask questions during the webinar, and we'll try to make some time available at the end of the webinar to answer any of your questions. Thank you again. So now let's start with the discussion on this such important topic. I would first like to ask you, Salome, one question is, how would you define equity? I think you muted and we can't hear you.
Thank you, Elsa. And I'd like to use an illustration to help us define equity, because we're talking about aspects of fairness. So there's an example that has been used before where you find that you're working in a population and you realize that they need shoes. And so you buy shoes, maybe one size of shoe for everyone. So giving everyone a size 6 shoe, and you feel that you have already helped people to have shoes. Yet we realize that people in that community don't put on size 6. There's some who put on size 3, there's a size 5, there's a size 6. So equity is ensuring that even as we are giving the shoe, we're ensuring that the shoe is fitting everyone. Each person has a shoe that fits them. So it's about looking at the fairness aspects. It's about ensuring that everyone has what they need and is on a platform that relates to where they are at. There's also the picture that usually portrays this, where there are 3 people who have gone to watch a football match, and they're watching from a fence, but they're different heights. And we decide that we give them all the same size of platform to help them see over the fence. But yet one person is shorter, the second person is maybe of a medium size, and the third person is much taller. So when we give them the same size of platform, the person who is shorter will still not be able to see, because the platform they have does not work with their heights. So equity is ensuring that everyone has the right size of platform that can help them see beyond the structures that exist.
Thank you, Salome. That was like really good examples to show the difference between equity and equality, actually. And if we carry on some definitions and what the word means, Robin, how would you define inclusivity?
Generally, inclusivity is said to mean embracing all people, irrespective of their race, gender, disability, cultural background, or medical or other differences. However, in order to achieve equity and inclusivity, it's important that we recognise that simply inviting different people to the table is not enough. It's crucial that we also identify and implement practices that enable them to contribute to the identification of problems and solutions in a respective, active, and an effective manner. So it's really about those actions that really demonstrate inclusivity rather than just the lovely photos, seeing lots of wonderful people involved.
Thank you very much, Robin. It's true that the wording here is particularly important. As I say, we often confuse equity with equality or inclusivity with integration. We talk about including people, integrating people. And so vocabulary is really crucial and can sometimes be undermining and lead to discrepancy. So Amelie, can you tell us a bit further? How can the terms that we use lead to inequity?
Yeah, thank you, Elsa, for that question. I've been discussing this topic with colleagues in the past years because not being a native English speaker, I think it's very important that we do our best to use the best wording or the best fitting wording because words have power. And the language we use in zoonosis prevention can unintentionally marginalize or stigmatize certain groups and ultimately, and again, unintentionally reinforce inequity. For instance, terms like Wuhan virus or vulnerable population may frame specific communities in a way that imply maybe or that blame them or dehumanize them or maybe imply passivity. And this is particularly important for population living near or in the region where an outbreak started. They are often portrayed as either the source of the outbreak or responsible for its emergence. And a clear example from the past years is a stigma faced by men who have sex with men during the early days of the HIV epidemic, where terms like gay-related immunodeficiency and public framing of HIV as gay disease led to severe discrimination of the LGBTQI plus community, undermining sometimes effort to control the spread of the virus. So it's very essential to use, I think, people first language, which puts the person before a diagnosis and that respect dignity. So we could frame communities that are the most closest or the most impacted by an outbreak as partner in prevention, for example, focusing on their active role or contribution to controlling the outbreak. So so effective communication relies on intentional transmission by the sender of an unambiguous message that is received and understood by the target audience. So we need to use inclusive terminology and be also mindful how translations may carry connotation across culture, different connotations across culture, and maybe co-creating message with the community. So I hope I answered your question. So over to you.
Yeah, absolutely. Andres, do you have maybe other examples, or do you want to carry on this answer regarding the terms that we use in general?
Sure. Thank you, Elsa. Well, first of all, I totally agree with everything that Amelie said, and I wanted to build a little bit on the part relating to how language can influence how effective interventions that we implement are, because of course, especially for prevention, interventions such as sensitization, awareness, education, for these interventions to work, they definitely need to be quite adapted to the local settings, especially to the social norms, to the potential taboos that there can be adapted as a non-specialist language. And so all of these are going to help ensure that these interventions are appropriately adopted across communities. But I will go even farther than that. And because the language that we use is going to affect and influence which interventions are prioritized. So, for example, when funding calls or policy documents talk about innovative solutions, right, in terms of disease prevention, that can lead a lot of that can distract a lot of the focus away from investing in basic needs that are necessary for communities to prevent zoonosis, such as, I don't know, access to water and sanitation, basic infrastructure, etc., and then towards more high-tech or novel solutions that are not necessarily going to be appropriate for those marginalized settings, rural areas, etc. Thank you.
Thank you, Andres. That's actually an excellent point here. Do you feel, and I'm opening this question to all of you, that sometimes by trying to be maybe too inclusive and using words that would kind of encompass everything, such as stakeholders, that's something that we're using sometimes without even thinking about the meaning of the words, or global south, or different words like this, by maybe trying to be too inclusive, we are losing maybe the exact meaning of our words, and why who would we try to include, for example, the word stakeholders, or other words of these types? Do you feel that we can lose actually this inclusivity and create maybe sometimes more issues? I don't know who wants to go first.
I'm happy to make a very brief intervention. Thanks, Elsa. One of the things that troubles me is that English is a very dominant language, and you use the term stakeholder. So for people who aren't familiar with that term, if they break it down into stake and holder, it can sometimes convey something very different. So it is, I think, very important before we start our work to, as you say, think very carefully about the words we use, and particularly where we're working in intercultural settings, work with our interpreters who understand not only words but culture, to ensure that we're going to be using terms that will resonate with people and that will allow them to feel that they can engage freely and openly. Thanks.
Thank you, Robin. So carrying on this, and what I was saying, that sometimes, as you say, some of the words can actually, I would say, lead to discrepancy and can be undermining. And we can also lose the diversity that is behind some of the words. And I would ask here, Amélie and Sandul, how do we consider social diversity in zoonosis prevention strategies? I don't know.
Should I start, or Sandul?
Yeah, you can start, and then Sandul.
So maybe I'll start with defining social diversity. It refers to the variety of differences within a society or a population, so including but not limited to race, ethnicity, gender, sexual orientation, language, access to health services, or cultural background, for example. So I think to effectively prevent zoonosis, we must fully integrate social diversity, obviously, and it starts by recognizing that different groups face unique risks. So, for example, rural farmers or pastoralists, they may be exposed to zoonotic disease through direct contact with livestock, while people living in urban area may be exposed to zoonosis through wildlife market or processed food. We can also think about a gender or sex, because diseases like brucellosis or toxoplasmosis, for example, they may have a serious adverse effect during pregnancy. So this shows also the risk related to sex. So it's important also to consider cultural attitude in zoonosis prevention. So for example, in rabies prevention, cultural and religious beliefs significantly impact how people relate to dogs. And what we know in Europe is different from what how people relate to dog in India or in Indonesia, for example. And maybe we should include this cultural view into prevention strategy, so to ensure that they are socially acceptable for the people. And I would like also to add that very important too is a need for diversity in the workforce, because a team that reflects the social and cultural diversity of the population it serves is better equipped to address the nuances of zoonotic risk and avoid one-size-fits-all approaches. Diversity in the workforce encourages creativity, innovation, and critical thinking. And without a diverse team, there is a risk of what we call group thinking, when we reach a quick consensus because we are an homogeneous groups that no one challenge. So, and this tendency of group thinking is more often seen during stressful situation, and we can think about sanitary crisis. So I think having a diverse workforce would avoid rush decision and would favor optimal solution in zoonosis prevention. Thank you.
Thank you, Emily. I can see that the audience is totally agreeing with you with the reactions. It's good that you also mention examples from India, because this is the perfect transition with you, Sandul. So how do you consider this social diversity in zoonosis prevention strategies? And I think it's important also to have your point of view, because you've been doing a lot of operationalization of One Health in India in the field. And so you know how it can be difficult probably to address all this diversity.
Thank you very much. And I think I'll just echo my co-panelist, Emily, and taking one example of the social norms of the practices. And that should be considered in terms of One Health operationalization, because let's say, taking the example of Indian setting where the cows or the livestock, we worship them. It's a cultural practice. So that need to be accounted in terms of different, comparing to the cultural context and the social norms, and probably some kind of social leadership or religious groups that we need to consider in terms of designing some interventions at a societal level. Because we do believe the society is heterogeneous, there are differences within the society, and that need to be accounted in terms of interventional practices. But that does not end the story here, because when it comes to the individual level within the society, so let's say the status of the poverty or the socioeconomic status of the individual, or let's say the educational status, because the way the people perceive the disease risk factors or the preventive strategies, that we need to understand from the policy perspective while designing those kind of interventions. So here the kind of like intrapersonal characteristics are more important in terms of social, and to include them into a comprehensive intervention. Same time, coming out from the society as a unit and then to the intrapersonal, there could be also understanding that we require it somewhere level to the interpersonal. So let's say there could be differences between the rural to the urban setting. And I mean, most of we agree to the like how the dispersion pattern that varies from the urban setting to rural areas, or probably some homogeneous groups, let's say the tribal situations or the tribes and so on into the different parts of the world. So we need to take that further into the account of all these diversities within the society into the designing the different types of interventions. I hope I could make that to surface. So over to you, Els. Thank you.
Thank you very much, Sandul. That's excellent. So this will bring me actually to my next point is, and say in a few words, and in regard to your field of expertise, what do you think would be the first barrier in inclusivity, and what would be the consequences of this inequity? Salome, can I start with you for this point?
Yeah, thank you about that. In the field where I work, especially looking at zoonotic diseases and looking at, for example, looking at Rift Valley fever or looking at trypanosomiasis, there's been experiences where we have found that the barriers towards inclusivity is when we don't have gender disaggregated data, because we find that interventions are, are done based on the data that exists. And if that data is not gender disaggregated, and when we are looking at livestock related aspects, we find that we will develop interventions that may only focus on men at the exclusion of women. Because within the livestock practices, many people talk about livestock being a male dominated activity. But when you go to the roles and the responsibilities, who are actually doing most of the work in relation to livestock keeping, livestock care, it's the women. So if we do not have gender disaggregated data that helps us to tell us who owns, who plays which roles and responsibilities, who makes the decisions, we may target our interventions, maybe training, to only train men because we think they're the owners of the livestock, yet the key people who may be able to utilize that information are left out. So without gender disaggregated data, we are assuming that the communities are homogeneous and therefore developing interventions that one size fits all, yet that's not the case. So it's important that we have that gender disaggregated data and realizing that even women themselves are not homogeneous. And so bringing in the aspects of intersectionality in all this will help us develop interventions that are tailored to specific targeted groups of people. Thank you.
Thank you, Salome. I think, Emily, you also have some experience and with the issue of the use of aggregated data then that can cause. I would love to hear more about that.
Yeah, thank you. I totally agree with Salome regarding gender disaggregated data, and we may also go a bit beyond gender disaggregated data and just speaking about disaggregated data in general. We have data gaps for some groups, subgroups, or community, and particularly in difficult to reach communities. And the lack of representation of certain communities or group of people, or the use of aggregated data, as Salome mentioned, that masks local differences, not only about gender, but other social dimension, including intersectionality, of course, prevents a clear understanding of the specific risks across these groups. And this inequity in data can lead to poor targeted intervention that would exacerbate health disparities and leaves ultimately vulnerable groups more susceptible to zoonotic diseases. So yes, addressing this data gap, the problem of disaggregated data, and ensuring a more inclusive representation of all group is crucial, I think, for developing fair and just and effective intervention. Thank you very much. Over to you.
Thank you, Emily. Andres, do you want to develop further with your experience in the field and in global health research?
Sure. Yeah, I would like to build a little bit on the data gap, and because in global health research, I mean, beyond the data gap, I think there's a gap in the type of evidence that gets prioritized and used. So, for example, when we're assessing which interventions work and which interventions should be implemented at scale, we tend to put a lot of focus on randomized trials, while the study of the real world effectiveness of these interventions in a diverse group of settings via implementation research is going to receive much less attention. And so this can result in interventions that look very good in control settings, but then are going to fail in practice because the real challenge is often, how these interventions are implemented on the ground. Another example that goes back to the disaggregation of data, but is related to the type of evidence that we use, is that we tend to put an overemphasis in global studies for predicting and modeling infectious or zoonotic disease risks, under the premise that because they are applicable everywhere, then these studies are more generalizable. But of course, these studies come with a set of trade-offs in terms of data quality, assumptions, the uncertainties and resolutions that the predictions can. And so this can lead to a misrepresentation of the disease risk for specific populations, or just the fact that they generate predictions that aren't actionable at local scales by operational actors. And so the consequences of this sort of evidence gap is that interventions may be misaligned with the actual needs on the ground and leave potentially populations that are vulnerable at greater risks.
Thank you on this. Robin, may I ask you to take the floor to let us know what you think would be the first barrier here, and what are the consequences of this inequity?
I'm going to give you a little bit about my background to explain why I'm going to raise this issue. I was born and raised on a small sheep and cattle farm in Australia. And when I went to study veterinary science at university, I was surprised to see how many of my lecturers did not understand or appreciate that why farmers do what they do. Often they would speak very disparagingly, very negatively about farmers not following the advice that was given. However, my understanding is that if you don't understand the farming system and you don't understand the complex situation and the difficult decisions that farmers have to make, then it's going to be hard for you to understand how they make decisions. And I found this as I've had the privilege of working in different countries around the world. Farmers do the best they can with the resources at their disposal. And if people who come in to help take time to listen, take time to understand the production system, the farming system, and work with farmers, then you're going to have a much clearer channel of communication. And if you seem like you're a good listener, if you do want to understand and you appreciate how difficult it can be to farm, people often share really crucial information with you. And I've often found that the most important information is actually given at the end of the day over a meal that we share together when we have the chance to stay in community. So for me, the key barrier is about professional attitudes and being open to learn from those with whom we're working. Thanks.
Thank you, Robin. Sandul, can I also have your input on this question?
Yeah, thank you. And I think I'll bring one more layer to these barriers, more about the, let's say, the national or regional differences. Because when we talk about the differentiations and the difference, there are a lot of context-specific inclusivities are present. So let's say we do have one policy for the nation, but the states or the province, as the context is quite different. So one level of diversity on the policy is not applicable to the different states and so on. So what we think, there are national level differences or the geographic, the international to national differences. Within the country also, we do have the nation to the state level differences. So that could be need to be accounted when we talk about the different levels of barriers. Thank you.
Thank you. So do you want to, any of you add, because we have some time, if you want, I say, what would be the first barrier? Obviously, and considering your answers, there are many. So if you want to expand more or maybe give other examples, just do you want to take the floor?
Else, I'd like to add
Yes,
one
absolutely.
I'd like to add another barrier, and this is looking at the discipline aspects. When we look at zoonotic diseases, we find that most of the disciplines that will push the agenda of the zoonotic diseases are mainly the veterinary, people from the vet discipline, from the medical discipline. And sometimes we find that even the interventions run along with these two disciplines at the expense of other disciplines which are equally important. For example, I'm an anthropologist, and I worked in an environment where we were dealing with diseases, trypanosomiasis, from a multisectoral approach, but a multidisciplinary approach. But one of the disciplines that was sometimes left behind was the social sciences, the anthropologists, because they didn't see the importance of anthropology in dealing with vaccination of livestock. And so sometimes when decisions have to be made in terms of who do we take on board when we don't have enough space in a vehicle, the social scientists sometimes are left behind and the technicians are carried on in the vehicle to go and do livestock vaccinations. We had a situation where the vet left the social scientists, and when they reached the field, they didn't find anyone coming for the vaccinations. And so the next day they had to call us to come and find out for them, why aren't people bringing their livestock? And we came to realize that it was social issues, just understanding the social dynamics in the community, the roles of the different people in the community, the social cultural contexts, helped to be able to understand why people were not bringing their animals for vaccination. And that helped to change the strategy they used, and the next day they were able to have many more people coming for the vaccination processes. So discipline-wise, also sometimes there are iniquities across disciplines. Some disciplines are not represented, yet they are very important. The environment needs to come on board when handling zoonotic diseases. And so that's also something we need to take into consideration. Thank you.
Thank you very much, Salome. Actually, this is so important. And this is so important that we will come back to that later, but regarding this acceptability of interventions and how we can enhance that. But I would also like to come back to this idea of different layers of equity. And as you mentioned, central, like local, national, regional, global, and the idea of the context is really important, because this will bring each layer, each level will bring different equity issues, or will have different barriers. And regarding the difference that is made, so I think the recent OLEP definition of One Health included the word equity there, and we say One Health is about animal health, human health, environmental health, and there is still so much difference that is being made between these different health sectors. And even more, depending at the level of you stand, at the local level, there can be a strong difference. At the global levels, we think that it's fine. I mean, all these different health sectors are accounted for, but it's definitely not always the case, depending on the context. Absolutely. I think I could check that there were some questions from the audience on this specific topic. So we might have some time for an answer. There was a question from Kranti Visyaraju, where Sandul, I think you would like to answer to this one.
Yeah, thank you, Elsa. And I think it's really the context specific. And also, I'll build up on the last point what my co-panelist Salome was talking about, the discipline. Because when we talk about this equity issues, to healthcare matters a lot. And when we discuss about the access to healthcare, we do understand the number of, let's say, the veterinary colleges are far less than the number of medical schools. And that could be, I could talk more into the context of India. And we have an accounting of that, the number of veterinarians we produce per year is probably 1/10 of as compared to the medical doctors. And that ultimately affects to providing the healthcare services either to the human health or to the animal health sectors. And when it happens that it comes to the interest or the influence of different policymakers, I think what Dr. Kranti is asking is about the how this power making and accountability comes, and the differences between two sectors takes a major role. And of course, that depends on the number of human resources that we devote to the human health sector or to the animal husbandry and the veterinary sectors. And that makes a major difference. So that could be my point, is that also maybe complementing with one more example of let's say the access to the vaccination services, the level of vaccination that we provide within the human health is bit of more structured as compared to the animal health sector. So that makes it a huge difference and interest to the policymaker or working in the respective settings. I think that could be my submission here for that particular things. Thank you.
Thank you, Sandul. Indeed, access to health, whether it's health training, health resources, health is so important here, and can create so much discrepancies between different communities, different people involved, even whether it's local, national, or even global level, definitely. So considering all these examples that you mentioned, all these barriers that you mentioned, and the example cases of inequity, I would like actually to say how, therefore, can we focus on disease prevention in a way to be most effective, but also to engage most of the people. And as you previously said, Emily, how to take into account all this diversity. I would like to ask first, maybe Robin and then Amelie about this.
Very much. It's a really good question. In my experience, effective disease prevention really requires a very good understanding of the local context. For instance, particularly if you're working in underserved areas and under-resourced areas, it's really important that you understand how the local community views the etiology of disease. For people who have not had formal education, they may not have been exposed to the germ theory of disease. They may have a very different explanation for what's causing disease. So if we arrive talking about disinfectant, talking about vaccines, that's not really going to help if the perception is that there are other and possibly supernatural forces at work. So understanding those perceptions, also understanding what are the local disease priorities and what's been the history of disease control. What I found is that in a number of areas, once again in underserved areas, where disease surveillance is not commonly practiced, where the regular control of vaccine preventable diseases in animals does not occur, what can happen is that if there's a report of an outbreak, the Animal Health Services will respond with vaccination. So what can happen is that animals that are already incubating disease, they get vaccinated and then they die. And the farmers are left with the perception that the vaccine has killed their animals. And this can be a really difficult experience to turn around. So that's very important that we understand. Is there already a good trust and good experience between the community and the health services, or is there a history that we need to understand? I was also very grateful. A couple of years ago, I was able to participate in a disaster risk management conference being held in the Asia Pacific region. And there was a really impressive speaker from Nepal, Manisha Dakal. Manisha is a transgender woman. She works with the Blue Diamond Society in Nepal. And she really explained very clearly how difficult it can be for people who don't fit the norm in terms of being classified as male or female. They can have difficulties getting formal ID cards, getting registered. And all of this means that they will be excluded. They will be excluded from registering if there are activities taking place. In the case during COVID-19, when their support community that was trying to get out and to distribute medicines that were needed by some of their members, because they didn't have formal ID cards, they were unable to pass police checkpoints. So there are all of these different issues that we need to think about. How do we enable people to engage? How do we enable everyone to get access both to the services they need and to have their voices heard? Thanks.
Thank you, Robin. It is indeed like the exclusion of some people can definitely have so many important consequences on health management behind. Amelie, do you want to follow up on that?
Yeah, sure. Yeah, I think what Robin said about understanding local context is extremely important for disease prevention, and maybe prioritizing cultural or intercultural competence is critical by like recognizing and addressing culture and health disparities in our strategies of prevention. Cultural competence means that is the idea of effectively operating in different cultural contexts and, very importantly, adapting practices to reach different social-cultural groups. And a culturally competent prevention strategy would be a strategy that respects diversity in the patient population and cultural factors that can affect health and healthcare, maybe language, communication styles, beliefs, and behaviors, for example. And this could be done through the co-development of prevention strategy with the affected community, ensuring their voices are heard through the planning and implementation, and letting them maybe also define themselves with their needs and define their needs with their own words. So that would help create solutions that are culturally appropriate and maybe more likely to be accepted and to succeed. And I come back with that to the workforce diversity, because diversity within teams would significantly boost community participation, especially when researching minority population. It has been shown that when team members share cultural, linguistic, or lived experience with the communities they research or serve, that help building trust, open dialogues, and also support recruitment for studies. And so that also ensure that interventions are culturally appropriate and appropriately communicated. And the last thing I would like to share regarding how to be more engage more people. Sorry, it's from my own experience when working in unfamiliar context. I would say I'm trying to approach fieldwork or sometimes just data analysis, or if we work in prevention program, approach that unfamiliar context with humility and open mind, because it's important to resist making assumptions based on my own cultural background or my previous experience. And as Robin mentioned, take time to talk to the people to understand and appreciate the unique social, cultural, and economic context we are working with. And that would also make this prevention strategy probably both socially and ecologically just. Yeah, thank you very much.
Thank you, Emily. I actually would like to open maybe the floor to you, Andres, Salome, and Sandul. Do you have, with your own experience on the field in research or in different project management, where do you have examples where you managed to you could focus on this prevention and manage to engage most of the people or in a very effective way? Do you have examples I would like to share? Sandul, yeah, I can see that you agree with that. Please go ahead.
Thank you. And I think that's a great question and also a point of importance to discuss, because often what we hypothesize is that all the interventions we think are quite great and we think the interventions are really nice. But when we do kind of evaluation why these interventions are not making any impact in the society, we try to have the document that, okay, this went wrong and something. So that's the factor of acceptability comes and why it has not been accepted by certain communities. So I want to bring a couple of things here when we try to design or we try to enhance the acceptance of any interventions. The first thing that we should think is about how you involve the community into your co-creation process. That means you take the example, you design an intervention as a scientist, but you go back to the community where you are targeting and try to develop, co-create the knowledge with them so that probably the intervention, the strategy could be very effective in terms of acceptance at the community level. Probably the second, I mean, we should also think in a perspective that take the assistance of the community leaders or let's say the religious groups. And one example I could draw from the past project is that we really took the help of the temple owners, the priest or the church owners. I mean, they were the people who really translated the knowledge of intervention, why this is important in the vernacular language, which is more palatable by the community, and it was really accepted by the target population. So take the advantage of them. The community leaders are really the steering people who can help you out to intervene very effectively. Probably also we should think in some sense to take the advantage of public-private partnership, I could say. Like we do have a lot of knowledge exist within the private setting. Bring them out, take into account them that they can also contribute to your interventional strategies. So I think the taking the advantage or the strong ownership of that intervention at different levels. Either it could be a private sector or it could be a religious group leader or the societal, the leaderships also take them into the participatory approach of intervention. And I think this combinedly and co-effectively will make your intervention very acceptable at the community level. So that's my perception and the learning so far. Thank you.
Thank you, Sandul. So actually, this is really linked together. Being effective, engaging most of the people will enhance acceptability of any interventions in the field, definitely. Salome, would you like to carry on that?
Yeah, interesting discussion and very useful. I build up on Sandul's sharing and also what has been shared by my other panelists. Again, to look at a practical experience that we had in Kenya when we had an outbreak of Rift Valley fever in the northern part of Kenya. And the communities that are here are mainly pastoral communities, and they depend on livestock for most of their economic aspects, their livelihoods, cultural practices. And so at one point in time when there was an outbreak of Rift Valley fever, it also coincided with a time when the community here, who also subscribed to the Muslim faith, the Islam faith, had a religious festival that was meant to happen. And this required that some animals would needed to be slaughtered as part of a celebration. And this became a tricky situation because of the outbreak of the Rift Valley fever, because animals, livestock are part of the disease is zoonotic. Rift Valley fever is zoonotic. And so how did how was this solved? How was this situation solved? By working with social scientists who are able to understand the context of the community and realizing that the religious leaders, the imams, were important players in this community and are always listened to by the community. The government decided to work with these religious leaders and discuss with them about the risk that the slaughter would be able to, slaughtering of livestock would create within the religious festival, having the religious festival at that time. And they came to a compromise where the community now listened to the religious leaders and did not slaughter so that they would not be open to risk. So what I would say is about utilizing the local community structures, the trusted sources, because trust is such a key component in terms of acceptability of interventions. If we work with people who communities don't trust, then acceptability of interventions becomes a challenge. And then the other thing is also about understanding the socioeconomic social-cultural, historical, and political background and context. Because interventions are implemented within these contexts. And if we do not understand what has happened in that community historically in relation to disease control, what are the power dynamics that exists in those places, then we may bring about interventions that may be contrary towards those social or may perpetuate some aspects that are negative that have been there historically. So understanding those contexts help us to be sensitive to the community's context and to develop our interventions in a way that may get more acceptability by the community. And then amplifying the voices of the community is also very important because when we're developing interventions, we need to amplify the voices of the community, have the community also part of that co-creation that Sandul had talked about. They need to be on the table from the beginning, not as end users, but also as creators of these interventions. That would increase their acceptability.
Thank you, Salome. It's moving from this top-down approach to this bottom-up approach is I would say of primary importance here. Obviously, yes, that's definitely the case. And it's not only about communicating effectively, so having the right message with the right person identified in the community, but I would say maybe it's also speaking, and it will come back to what we said at the beginning of our discussion about the language. And I think, Robin, we had this discussion before because Robin is part of the Pillar Working Group 5 of PRESOD, where we have this big discussion about community engagement. And we talked a lot with you and other experts about this issue of language. And Amelie, you said before, English is usually the main language, and it's not always easy to communicate effectively. And I think when you try to implement some actions or to make some interventions acceptable, I think, and Robin, maybe you want to follow up on that, but language can be a strong barrier. So you have the right person that need to transfer your message, but you also need to speak the language of the people you want to work with, I guess.
And in many cases, if at all possible, it's ideal if you don't speak the local language that you are actually not the person who's seen as the person facilitating the discussion. You can support people, or if you have to work and speak, really having a prior relationship with your interpreter is really important if you can, because they know the community. They also will have a feel because you will have discussed the issues in general, and they'll have thought about what are the best examples, what are the stories, what are the ways of communicating these, often English terms, but in meaningful ways. And then they also have the ability to feed back to me in ways that can help me to understand the insights that the community have. So I guess the question here, it's not only about language, it's about time, because two-way learning takes time and you won't learn it all in the first meeting. Thanks.
Thank you, Robin. Andres, I'm pretty sure that you will have so much to say regarding the necessity of a bottom-up approach. I think we'll come back to that later if you want, unless you want to you have something that you want to discuss a bit more now.
I mean, maybe just give an example of, both of the timing, the fact that things need time, and also about what Sandul mentioned in terms of private-public partnerships and bottom-up approaches. Just the example through my research, I've spent the past 10 years working on doing research in one rural district within Madagascar. And the idea there is not to, come with a nice research idea that people need to implement and then we are going to evaluate, but it's rather there are people on the ground that are implementing programs that are trying to mostly just improve the health of the population. And so what we're trying to do is build research systems and data collection systems that are not driving the implementation process, but are rather informing it. right? And so throughout the process and throughout the years, we're providing information and evidence in terms of effectiveness, in terms of barriers of the population, and then those are making and helping adapt the intervention over time. So just, one additional example of how these things work.
Thank you. Thank you very much for this good example. I would like to move now to one of our next question, and we talked a little bit about it before, but it's the idea of equity across the different health sectors, and how can we ensure this equity? Andres, carry on with you and
Sure. Um, So, I think in order to ensure or at least improve equity across different health sectors, whether we're speaking about human, animal, or environmental health, it is crucial to simultaneously try to understand and address two things. On one side is the barriers and challenges that local population face, but also is the resources that are needed for local actors to effectively implement these strategies. So, building on the experience that I've had in Madagascar and specifically on the human health sector, but I think it applies to other sectors. Generally when we want prevention interventions to work, like vaccination, or we're trying to implement integrated surveillance, for these interventions to be effective for disadvantaged populations, we need to ensure that these groups can actually access care, right? Because without access to care, then they are not going to receive the interventions. They are not going to count into the cases that are reported by surveillance systems. And so that means addressing barriers such as financial barriers, geographic barriers, cultural factors that are preventing these populations to access health services. So in the case of the setting where I work, 80% of the populations live under the poverty line. More than half live farther than an hour from a basic health center, more than 2 hours from a hospital, right? And so if you don't take into account and address those barriers, then those people are not going to count into, disease cases reported. They are not going to be beneficiaries of the prevention interventions that we're trying to implement. And when we look at the resources, resources are often concentrated at the central level and in urban centers. So for zoonotic prevention and management strategies to work equally well in both remote rural areas and cities, there's always a minimum and a comprehensive set of resources that are needed at the point of care, right? You need at the same time to have trained healthcare workers, you need adequate infrastructure, you need availability of materials and supplies. And without all of those things, you can build or try to build any prevention and zoonotic management strategy that you want. But the only thing that you're going to do if the system is weak and is not functional is just going to reinforce existing existing disparities that already
yeah,
do there.
definitely this will deepen this discrepancy and the inequities between the populations. Yeah, thank you very much, Andres. Sandul, can I ask also your opinion about how can we ensure this equity across the different health sectors? And it can be health sectors the way Andres mentioned it, but we can also talk about these differences that can be made between, for example, when we talk about One Health, different health sectors that it encompasses.
Yeah. So thank you very much. And I think I'll start bit of more one step down of when we talk about One Health and the different sectors. I do really doubt is that till now have we emphasized or integrated the environmental health into One Health? So that's the big question I do have. I mean, even to the global community should rethink how to position the environmental health within the larger component of One Health, because at least what we experienced so far on implementing the One Health programs in India and certain some parts of Ghana is that at least the One Health concept is well perceived by the human health professionals and animal health professionals. But when it comes to the environmental health, the priority changes. Taking or building the points of Andreas, what he was talking about, the surveillance system, at least we do have a robust surveillance system for human health and for certain specific conditions for animal diseases. Coming to the environmental sectors, of course, there is a meteorological monitoring system and it's to exist. But it comes to the equity, what language they speak is a bit different because the priority or the governance structure is different across the sectors within the One Health. So the first thing what I would like to highlight is when we talk about equity across the sectors, we should prioritize, and building the same point of Ravin's is this, we need to define the common language across these three sectors. Then only it will be probably we can make a good balance between three sectors within the One Health domain. The second point, we do understand the different sectors has their own capacity. Let's say the human health could have a better surveillance system for disease X, whereas the animal health should have another surveillance system for disease Y. But it is quite important to cross-learn those things and to make it is a very balanced surveillance system, or when we talk about integrated disease surveillance within the system of One Health. So that could be the second point that I would like to highlight. Last but not to conclude is that, of course, take the ownership or accountability of these different interventions, what I already highlighted, like taking the private sector into the engagement and to build that equity across the different sectors, also across the different stakeholders, because that is important. And I remember that initial we started with discussing the stakeholders. I would really like to brief that stakeholders could be a policy makers, the stakeholder could be a community member, but we need to come up with a forum and speak in the same language of whom we are talking and what we are talking. Then only it will be the equity can be developed. That's my perception. Thank you.
Thank you very much, Sandul. Amélie, Robin, and Salome, I could see that you were strongly agreeing to what Sandul was saying. Do you want to add something before we move on to the next questions? Does one of you want to add something?
Maybe quickly on the One Health framework and equity between sectors and discipline, it's pivotal for zoonotic prevention. And Sandul is right; it's not well implemented so far. And yes, I think it's a major issue. It's a major challenge we need to face and to overcome to fully have an integrated approach to zoonotic disease. So yes, equity across sectors and disciplines seems pivotal to me. Yeah, thanks, Sandul, for raising that problem.
Thank you. Thank you very much to you. My next question would be, how can we reach equity in research and policy? So we talked about that a lot, and in research, but obviously not only, but we want to make sure to be equitable and inclusive when it comes to data collection, data processing, data accessibility, and data sharing. So we talked a lot before about the need for disaggregated data, not only for gender, but for different different topic. Amélie and Salome, can you tell me a bit more about how can we make sure to be equitable when it comes to data and all from collection to analysis and sharing?
So should I start? There's a lot to
Go
say
ahead.
here. Okay.
There is a lot to say about that. We covered it a little bit before, but yeah,
True.
please.
So yeah, I think we spoke about this already before, about this basic data requirement to ensure that no one is left behind, and it's using disaggregated data. So because it can show underlying differences in zoonotic risk or exposure or underlying inequality patterns that are not evident if we do an overall average across population. So data collection first must reflect the diversity of the communities, of the regions, of the subpopulations or subgroup, while of course adhering to ethical standards, preserving anonymity and ensuring informed consent, obviously. We can, for example, use stratified sampling or simply oversampling the minority groups in surveys that would allow for sufficient sample sizes across population subgroups and help ensuring that disaggregated data can be used for measuring exposure or risk to zoonotic disease across groups. So in descriptive epidemiology, and it has already been touched before, we can use double or multiple disaggregation. It means filtering data according to two or more than two social dimensions simultaneously. So for example, gender and income. And that would permit a quantitative exploration of intersectionality. And we've mentioned also that before. And that would allow us for a deeper understanding of the risk. And again, ensure that intervention could be tailored to meet specific needs. And principles that are important to my work are the principle of fair data. So I think that promote equity and inclusivity in data management. We want the data to be findable, data and metadata, so they would be easy to identify and locate for all. For example, we could do the metadata, write the metadata in the local language that would make them accessible to non-academic stakeholders. We want the data, of course, to be accessible. We want to guarantee equitable access to the data. And we also want them to be interoperable across sectors and disciplines. And finally, we want them to be reusable, so that would allow others to build on past research. But beyond the FAIR principle, it is also important to ensure data or digital sovereignty for members of local communities or populations or subgroups by actively engaging with communities through the entire data cycle. It means collaboratively designing data collection strategy, ensuring ownership. This is very important. And also ensuring that the community decides what data should be collected, how they should be collected, and how they could be reused. And of course, that comes with increasing the local capacity to work with data. We need to empower everyone, every subgroups to work with data, and then enabling them to really engage in the data management and take ownership. I think it's very important to remember and to always think about how data and data practices impact people's rights, especially as digital systems and data-driven policies are playing a bigger role in our lives. So it's very important to consider equity in data for the entire data cycle. Thank you very much.
Thank you very much, Emily. Just to carry on this specific question, I will actually take two questions from the audience, and before Salome, you can follow up. The first one was from Dan Ving. Thank you, Dan. He was asking if disaggregating by gender was enough, but actually disaggregating data, not even by gender, but is it enough? And his question is, how can we go beyond disaggregation of the data? That was one of the first questions. And the second one is from Natalia Sediel. Thank you, Natalia. And she's using participatory research action methods in her work and would like to have your opinion regarding participatory methods when it comes to data in under all its forms. Salome, do you want to start on this?
Yeah, thank you for those questions. Very good questions and very good reflective things to look at. So in relation to the disaggregating by gender, I agree that that's just the beginning part, but there is much more to go beyond disaggregating data. And I believe that's where also the participatory methods comes in terms of how do we collect our data. So first, we usually disaggregate our data. Yes, we can say men, women, or people of different socioeconomic status, but that's not enough because there's usually much more in-depth information that sometimes just the disaggregation of data may mask. So by use of other methods that help us to go more in-depth, qualitative methods to help us address more issues that disaggregated data may not be able to tell us. And that's using methodologies like the qualitative methods, ethnographic methods that help us understand the questions why and help us to understand things that we may not be able to see on the surface. Bringing me to the participatory research and participatory methodologies, they're very useful in terms of ensuring equitable and inclusive data collection processes, because this helps us to bring people who may not be able to understand the language that maybe the mainstream research questions are all about, but working with people in using locally available things to be able to gather data. For example, we've done participatory mapping where we use we work with the community to be able to help us understand how the community landscape is, and we question why is this like this. And in the process, it's an empowering process, because as we are gathering data, it's empowering both the researcher and the community. And so it's a win-win for the two groups, so that it's not just me as a researcher coming to the community to extract data, but it's me coming to the community to work with the community to be able to find a solution towards common problems they have by working with methodologies that help them to participate in the process and are able to help generate the data. And that goes all the way. It's not just collection, but we're able to process that data together and are able to then question and see how best can we work with our findings to improve on what is happening. But as I also answer that, I want to look at it from also the level of the power dynamics that also exists in data collection. It could even be collaborative research that we have, maybe between the South and the North. Who accesses the data? Sometimes we find that in some collaborations, data is collected in the South, shipped to the North. The South are not participatory in that data analysis, sometimes don't even have access to the data that has been collected. And so working within frameworks that can help us protect both the North and the South to have equitable relationships in terms of data collection and data processing, and the use and the benefit from that data is also something that is important that we need to look into.
Absolutely. Thank you. Thank you very much, Salome. Just coming back quickly to the participatory methods in One Health. I think, Sandul, you have a good experience into that. Would you like to answer also a follow-up on Salome's answer to Natalia?
Yeah, thank you, Salome, and thanks for bringing that context of Natalia, that participatory action research is really, really important when we talk about bottom to top kind of data building or generating evidence. Let me give one small example. What we did is, all we know the epidemiological triad of any zoonotic conditions, but despite we know what is the agent, host, and the environment, how it spreads, we went back to the community and we sit together with the community members to draw the same epidemiological triad, what they think there could be the environmental factors. And what that additive knowledge bring to us is that to identify different types of proximal and the distal factors for the disease occurrence. And that really helped us to design a new intervention strategies for that particular zoonotic condition. So a small tool that we have used is called photovoice methods, where we distributed a couple of cameras to our community members and asked them, okay, can you picture us one photograph and come back and say that which is the dirtiest place within the community that lead to the disease occurrence, which is a very palatable language of data collection or generating evidence, but it was most doable by a community member who is even illiterate. So such kind of action research, the participatory methods are really, really useful in terms of evidence generation. And I mostly appreciate that you are into doing the PAR. So keep it up. Thank you.
Thank you very much, Sandul. I think we could talk about this data collection to analysis and sharing for hours. But we have to move on. And so my big question was, how can we reach equity in research and policy? So we can talk a lot about data, but Andres, how would you say research should be conducted? Might not be the best terms, but how can we reach better equity in research?
So I think in terms of research, and building on what Salome was mentioning before, specifically in the context of the global north-south divide, if we can say it that way, one of the things that we need to ensure is that both the design and implementation processes are more inclusive and fair. And so, for example, in terms of research, priorities are often set by funding agencies. And then research projects, there are calls, and then research projects tend to be shaped by expertise and interest of researchers in high-income countries in many cases. And so that is fine in other contexts, but in the context of zoonosis prevention in the global south, then this creates dynamics, a dynamic of power imbalance that leave out critical input from national governments, research institutions, and local communities in the south. And these are precisely the communities that are supposed to benefit from the research. And so there are many ways that we could address that, but a few of the things that we would need to do is, to continue efforts on building local research capacity, whether it is for data collection, but specifically for data analysis and interpretation and communication of the research results. Of course, directing more funding specifically to institutions in low and middle income countries. And then one other thing that could be done is encouraging practices such as the author reflexivity statements in journals that some journals are already starting to encourage or mandate, which tend to hold like researchers accountable. At least they have to describe, their positionality, the power dynamics that were involved in the research study. And so these steps could at least help improve that research is more equitable and relevant to local contexts.
Thank you. Thank you very much, Andres. Actually, so we are running out of time, but there was a point in the questions where Annabelle Daburon was asking about the attractiveness of inclusive approach to donors or public force. They say attracting more fundings is like bringing this inclusive approach could, or at least emphasizing on the inclusive approach. I don't know if it would be more attractive to donors or the public force, but that's, I don't know if that's something that that could be helpful. What do you think?
Yeah, I mean, I think so.
No, but that's, I mean, that's a, I don't think there is right or wrong
Yeah.
answer. Is about like, I'm not exactly sure if it's. I know that we're talking a lot, for example, about impact when it comes to funding. The impact that your research will have, the impact that your program will have. So that's something that can be attractive to donors or funders. I don't know if the inclusive approach. I think that's a completely open question, and probably everybody will have a different opinion on that. But I'm not exactly sure how attractive it can be. And Robin, if I can, so we talked about research, and what about also policies? What do you think about how can we reach equity or better equity in policies?
Thanks very much. Andre talked about the division between the global north and the global south. I think I'd like to go back to your point about equity across the different health sectors. So I'm going to talk a little bit about the division between the human health sector, and I hasten to add that I know those of you in the human health sector will say you don't have sufficient resources. But what I would say is if you want to feel better, have a look at the resources that we have in animal health. And if animal health people want to feel better, have a look at the resources available to the environment sector. the challenge we have is that the way we're approaching health is through a Western lens. So if Indigenous knowledge systems were informing our activities, Indigenous communities understand that our health, human health, is completely inseparable from the health of animals, from the health of plants, health of the environment. And if I'm healthy but my community is sick, then I'm not really healthy. So when we're working, because we're working largely within these Western frameworks, I think really the animal, plant, and environmental health researchers and practitioners, we need to do a much better job of explaining the co-benefits of why investing not only in research, but in policies that tackle these wider issues, why it's so important and what the multiple returns are for many countries that are facing challenging budgetary situations. The other thing that I think would help would be to have the coordinating bodies, so One Health secretariats, placed above the frontline agencies. So, for instance, within the UN system, it would be lovely, in my opinion, if the One Health Secretariat could also be located in their Development Coordination Office, which also serves as the UN Sustainable Development Group Secretariat. At the national level, maybe the One Health Secretariat should be in the President's office or in the Prime Minister's office. And what that does is help to bring the different sectors together, and not only just human health, animal health, plant health, environmental health, but it can also be the energy sectors, transport. All of these groups are involved and facilitate the movement or prevent the movement of pathogens. So I think when we're thinking about policies and how we get policies that enable the various sectors to collaborate, we're going to have a much more effective engagement if the frontline agencies are not leading, but are being coordinated by a body that they see as a slightly higher authority. Thanks.
Thank you, Robin. Still a long way to go, but hopefully some governments will hear you, actually. So my final questions would be, because in the introduction, I mentioned what PRESOD was about. And my question would be how initiatives such as PRESOD, but not only, can help tackle equity issues and empower communities. So Andres, you've been involved a lot in PRESOD and its creation in particular. Would you give us your input on that?
Yeah, sure. So, I think equity has been a central focus of the Preserve initiative from the start. And as you mentioned, like I was involved since the beginning. And one key approach that we tried from the beginning was the co-construction of its strategic agenda, which involved, like hundreds of people. And this was done through so a series of regional workshops that we're trying to give a global idea of what were the priorities, but focus on like what were the regional specificities. And each of these workshops involve a diverse group of stakeholders. So it involved people from the civil society, research institutions, governments, at least to try to ensure that there was a wide set of perspectives and priorities that were represented. Of course, the process wasn't perfect, but we try to use all of that in order to build this strategic agenda. And then I think in terms of implementation, I'm part of the what is called the PREACT operational research program. So PREACT is Pre-Sod in Action in the Global South, is one of the operational research initiatives that are going on right now. And I work in Madagascar with colleagues from CIRAD and local institutions. And so what we are trying to do in Madagascar, but this is the case in other countries, is that we place a strong emphasis on community level approaches, both for trying to improve integrated disease surveillance, but also for for risk reduction. And so at least I think this bottom-up focus can help generate evidence that is more grounded in the realities and needs of local communities. And then because PRISOD is, there are international organizations that are part of PRISOD, and PRISOD is present in international forums, then we can share the experience of these bottom-up approaches and have an influence at a broader scale.
Thank you. Thank you very much, Andres. Salome, and actually I'm opening the questions. Here's our final points. So if either of you wants to follow up on Andres's response, because I say it's not only PRISOD, but there are many initiatives that try to tackle equity issues, or by when they were built, or in the way they are functioning, try to address these issues. Salome?
Yeah, one of the ways that PRISOD can do this is by pushing through advocacy at global meetings, in meetings where maybe the global leaders are, to be able to talk about the issues about equity in zoonotic diseases, equity in research, in some of these forums. And I know in one of the meetings, it was a One Forest Summit that was held in Gabon. PRISOD was quite active in terms of trying to get people to sign in to ensure that aspects of equity, especially when we're looking at prevention of disease, rather than focusing on control of disease, there was the push towards focusing on prevention of disease. And one of the things we know that when we're able to prevent disease, it also helps to contribute towards equity, because then when we don't have disease, then at least then we are at an equal level. But when disease comes, then the inequities again are heightened. So pushing advocacy issues at a global level to ensure that the global policies are equitable towards different partners and different players. But also having meetings like this is also one of the ways in terms of just sensitizing communities of practice on equity issues, so that even as we go out to do our research, we go out to engage with communities, in practitioners, policy developers, that equity is ingrained within our minds as we move along. So there are various ways that PRISOD can help, but also in terms of research, helping to shape the research agenda to ensure that equity is ingrained in the research agendas that are out there. Thank you.
Thank you, Salome. I think we are now reaching the end of our webinar. Thank you to you. I will give the floor to Catherine. Catherine is the communication officer of the PRISOD initiative, to do the final wrap up. Thank you again.
Thank you, Elsa, who is our science officer. Robin, Salome, Amélie, Sandul, and Andres for these intense and brilliant exchanges. And we had great inputs in our Q&A box as well, that we cannot go through all of them, such as barriers and implicit bias as barrier to inclusivity. We will keep them and provide answer in our communication and working session. Please feel free to ask us more through our channels. So we've seen that there's a crucial need to address the layers of inequity before an outbreak occurs. Preventing disease emergence stops inequity from appearing or being made worse once the disease is circulating. So prevention is crucial and therefore has to be understood and acknowledged with appropriate and comprehensive approaches to advocate, as said, for and design the right policies. I cannot summarize all the remarkable outcomes of this discussion, but I will highlight some of them. So among those comprehensive approach, we need integrating diversity and taking into consideration that there are no homogeneous communities. We have to improve communication by using precise, inclusive, and non-stigmatizing vocabulary, and collecting data in a language that is understandable and appropriate to each community. We have to have disaggregated data and how it is managed, making sure that we understand risks across different cultures, community, gender, ages, activities, works, and regions. We are to identify and implement practices that enable communities to contribute actively and effectively with all components involved in planning solution according to varying risks and local context. There's ensuring that all the people's voices are amplified and that their views and knowledge are incorporated in the design and implementation of intervention. We have to, importantly, building trust and implementing field programs that facilitate bottom-up and One Health approach with a diverse workforce, such as the one implemented by present members, PREACTS, or Smart for Health. These approaches will allow us to build strong recommendations that can bring to policy and decision makers. Also, we chose that today's discussion would touch only lightly one key issue, gender disparities. This very specific topic is the focus of our upcoming Presa Talks and Lecture Perspective webinar that we are organizing 1 month from now. So please save the date for February 20 at 2 p.m. CET. And again, all of you, many thanks for participating and attending our meeting today.
Thank you, Catherine, and thank you again so much for our brilliant panelists. This was an excellent discussion. I really enjoyed it. Thank you so much.
Thank you. Bye.